And this is, this is a tuberous breast, one of the best indication for this operation, and we need to move this submammary fold, and this is a very good technique because without any scar we can do this kind of dissection. We can dissect the skin, and we can move up the submammary fold if we need, and this is done with a normal needle 16 gauge. And here you can see the result. Of course, there's a lot of swelling, and here we can see in 2 months how the contraction of the volume, and the result at 6 months. But it's very nice to see how is reshaped the breast, and how is constant reshape, and this is the final result at 6 months. And it's very nice to do without any prosthesis and any scar. Another case of breast augmentation, normal hypoplasia. This is the project, flank, sacrum, external thigh, internal thigh, and knee. And this is the post-operative immediately result with the 130 cc enriched superficial and 200 deep layer. This is the result, of course, 1 week, 2 weeks, a lot of ecchymosis. In 2 months and 3 months, we have a lot of contraction, and in the lateral view, we see this contraction, and the patient was not very happy. So it's important, the weight of patient must be stable at the time of procedure, because the injected fat preserves the characteristic of its origins. If patient loses weight, she will lose some of the benefit of the procedure. Another case of breast hypoplasia project augmentation. This is the result at the end of the operation, and here we will see a much better result at 3 months. This is the volume, and this is the final result of this patient that is much more happy. But now I use also this technique when I have to put much volume also in ptotic breast. This patient that how Giovanni told us needs a vertical scar, didn't subset the vertical scar, so this is the program with a round block technique, and this is the result at 40 days post-operatively with this kind of amount of enriched fat and this asymmetry injection of the normal fat instead of a big, very big liposuction of the patient, because of course this is a combination of technique, liposuction and lipofilling, and many times the patient asks us the completely liposuction of the body. Another case of congenital ptotic breast asymmetry, we need the maxtopexy and augmentation, a lower liposuction. This is the program, vertical scar maxtopexy and breast augmentation with the symmetrization of mammary fold. This is the area where I harvest the fat, only flank and abdomen. And this is the result post-operatively immediately, and this is the result at 7 days post-op. So you see the result at 40 days of this maxtopexy and only the augmentation in the right one. And this is the result also in 40 days of the liposuction of the flank of the abdomen. So the double result we have with liposuction and this technique. Breast asymmetry with tuberous breast, augmentation and maxtopexy when raw block. This is the project. We have to consider all the distance and to project the operation with the round block. And this is the immediately post-operative result with a lot of ecchymosis, and here we see the result. And after 1 week, we have a lot of ecchymosis, and we see this kind of result. In 2 weeks, this is the changing of the breast, and again, this kind of result in 2 months. So in this case, for me, it's very interesting, like Dr. Feller said, to have the possibility to correct the breast without a prosthesis. So we can have 2 breasts without prosthesis and not one with prosthesis and one without. So here you can see the contraction we have in 2 months of this, but of course we can use again fat when we want to symmetrize. Lipofilling indication enriched for breast hypertrophy, tuberous breast, breast asymmetry, of course Poland syndrome and breast reconstruction, and also mastopexy. Technical peers in the breast infiltration of the fat be performed in thin rates, of course. The midline of sternum should not be crossed, and the fat should be placed only subcutaneous, subglandular, and submuscular. What about oncological concern, and what about radiological concern in lipofilling? We do preoperative evaluation. We can use mammography, MRI, ultrasound, and this is important because we want to know if there's calcification, breast cancer, and it's important in the postoperatively. And preoperative evaluation, we want to know if there are no signs of breast cancer, presence of cyst, and the volume evaluation with MRI to be compared with the post-op image. I'm doing a work about this. We know that fat necrosis is a benign inflammatory process, well known with mammographic aspect, but is not known very well, not clear with the MRI and the ultrasound. So we have fat necrosis every time we do also mastopexy, reduction, mastoplasty, and of course lipofilling. And these are the radiologic concern of lipofilling. Rim enlarger calcification we can have with lipofilling, but fat necrosis area are all cysts with thin-walled calcification, so we can understand very well the difference between the cancer. No suspicion of breast cancer before the procedure. Potential risk to disseminate cancer cell with the infiltration is the same risk of agoepilepsy. Can fat grafting confuse radiologic screening test and hinder breast cancer detection? No. Fat grafting can accelerate cancer detection, strict radiologic control after surgery, and lowering of mammographic density of the breast tissue. So, protective effect of fat grafting in the tumor breast, we don't know, but I want to show the last one work of Gino Rigotti, determining the oncological risk of autologous lipoaspirate grafting for post-mastectomy breast reconstruction. And Gino says, although further confirmation is needed, our results support the hypothesis that autologous lipoaspirate transplant combines striking regenerative properties with no or marginal effect on the probability of post-mastectomy local regional recurrence of breast cancer. So, any case, if the discussion is open, we do post-operative control 3 months, 1 year, once a year, and this is also something of much better because we can see and we can analyze the breast. Of course, very quickly, this kind of operation gives us a natural appearance, natural feeling, no implant, no scar. If we want, no general anesthesia, because we can do this kind of operation in spinal, epidural, and sedation. It's expensive launch surgery, limited augmentation, of course, harvesting problem, oncological concern. We talk about this till now. Complications are the same of liposuction, but with oil cyst and their absorption, of course. We prevent the thromboembolism with the guideline of American College of Chest Physicians, and we use only an antibiotic preoperative and postoperative, and pain treatment with paracetamol 1 gram every 6 hours for 5 days. We do not need any opioid for postoperative pain control. Thank you.